And thank you so much for joining us tonight at our district event. It is being hosted by Dr. Miriam Smith, who is our district president from Queens. She is also the chief of infectious disease at LIJ Forest Hills and a professor of medicine at the Zucker School of Medicine at Northwell Health. And it's being co-hosted with Dr. Aaron Glatt, who is our district president from Nassau West. And he is an all-around great guy. I've experienced. I laugh because he said I could say that. And he's a professor of medicine at the Icahn School of Medicine at Mount Sinai, and also chief of infectious diseases and a hospital epidemiologist at Mount Sinai, South Nassau. So we welcome them for tonight's meeting, Essentials for Leading Through Times of Uncertainty. And just before I turn it over to Dr. Smith, who's going to start us off, this is interactive. We love meeting new people at district events. So please feel free to turn on your video, to raise your hand, to put in chat, pop in chat where you guys are from, get to know each other, and please be part of the discussion. So welcome, and we're so glad to have you. And I will let Dr. Smith have the floor.
Thank you. Thank you, Amanda, for organizing the event. And thank you, Aaron, for co-chairing the event. Aaron and I go back many years. So this is a very brief presentation to kind of get your bearings. And again, you can interrupt at any point, ask any questions, any comments. This is actually very brief. So the learning objectives here are to identify challenges to patient care in the presence of a new virus. Both Dr. Glatt and I are infectious disease practitioners and longstanding subspecialists. So this was truly an eye-opening experience. We're also going to bring forth how we balance the demands of departmental leadership. I was chair for 12 years here with a clinical practice as an infectious disease active practice practitioner during this, during certainly the surge and the two subsequent surges, and understand the role of a hospital within a large healthcare system during a healthcare crisis. So what is crisis? I always look these up because I like to see what the definitions are. And essentially, this is not only a time of difficulty, but crisis has great implications for wide-reaching and potentially disastrous consequences for those of us. And I think it's probably almost everyone on this virtual meeting has gone through COVID, certainly has gone through what we've seen as the first surge, second surge, and third surge at the moment. So I just want to give you a brief look back. If you can, focus a little bit on the date. This is March 10th, and I'm pointing at the Hopkins map as this pandemic was evolving. We were literally at the beginning, and we at Forest Hills were at the epicenter, a truly eye-opening experience. So the state mandated that all of us increase our capacity by 50%. And especially in metropolitan hospitals that are already strapped for space and personnel to manage, this was really an incredied demand, but we did satisfy it. So we at Forest Hills, and we are part of Northwell Health. We're a 312-bed functional community hospital, part of Northwell Health. So we created 5 surge units. We increased ICU bed space from 18 with 2 negative pressure rooms to 59 all negative pressure, all within a few days, which is an unbelievable engineering feat. So to go along with the surge, we had to provide personnel in order to manage patients, and we were really socked with patients. We increased our intensivist coverage. We changed our resident coverage. Electives throughout the entire system for residents were essentially eliminated in order to manage our patients. We, as well as probably everybody, redeployed physicians who were not primary care practitioners in medicine or internists in medicine, or even ICU attendings. And the most positive experience I had here was my request to our voluntary attending staff. And at the moment, our voluntary attendings cover between 50 and 60% of our inpatients. I was almost begging them, please, we need your help. We need you, to unburden our full-time people, because we are inundated with very sick people. And I have to say, our voluntary staff really stepped up. As part of a large healthcare system, I think we were very fortunate to have a very well-established supply chain and the ability to maintain everything that we needed. We never ran out of PPE or equipment, and again, very fortunate. The term load balance, something I never heard before until probably March of 2020. Again, we're a very large health system. We were at the epicenter in March and April. Some of our sister institutions had patient room, and we were very lucky again to be able to offload our patients and transfer them to our sister hospitals. So we, again, are a functional 312-bed hospital. We actually transferred more than 400 patients to our sister hospitals in order to hopefully provide first-rate care and offload us, because we were really bursting at the seams. What do we want from a leader? Well, we want the leader to be responsible for what's going on, to be reliable, to be reachable. We like to think our leaders are, provide inspiration, and especially under circumstances like this, with a focus on what do we need to provide good care, actually continue to provide first-rate care, and still, if you will, take care of ourselves. Communication with transparency, absolutely key. I actually just attended the ID meetings about a week and a half ago, the virtual meetings, and one of the COVID talks mentioned the term "I don't know," and again, as a leader, I don't know really goes very far, because we didn't know very much, we couldn't know very much, and to be able to provide comfort and a safe environment just by repeating "I don't know, but I will try to find out" goes a very long way. And probably equally important, without question, was has to do with leader acknowledging the burdens that go along with healthcare crisis, especially this one. We had a very high mortality, obviously high morbidity, high mortality, and we as practitioners, we're seeing this every day. During a healthcare crisis, we need to know who our partners are. Again, we are part of a very large healthcare system that was very beneficial to us. Everybody involved needs to understand the problem and how do we get to the solution. And the solution really is to provide safe, effective care, as well as making sure that we are not burning out. How much influence do we have as a leader, and what resources do we have at hand? So again, just to go into the COVID crisis, the first wave, we did not have much information, especially at the beginning. I'm a long-standing infectious disease practitioner, and I actually spent 2 years doing bench research in virology, but this was absolutely new to me and to all of us. A concern was the health risk. This was a new virus. Again, I've never really been concerned about my own health per se, but I went to a multitude of websites to look at how people don and doff PPE. And the first time I walked into a room, I was actually sweating, not because of the PPE, but sweating because I was really nervous. We know there was a major social, psychological, physical, and economic impact, and we haven't completely succeeded beyond that. Unprecedented government intervention with travel restrictions, with mandates, with mask questions, trials that were being done, and hospitals were overwhelmed, especially in the metropolitan area. Certainly an impact on the supply chain, but as I mentioned, as part of a large healthcare system, we were able to get what we needed. There was at the same time civil unrest, which we are all very well aware of. And the vaccine development was an unprecedented, accelerated event with global, with a global input and cooperation. It was unbelievable. So in 9 months, we went from, we actually were able to get emergency use authorization for a new vaccine against a novel virus. Additional challenges as a leader in medicine. For me, competing responsibilities, I actually continue to go to the bedside as well as provide leadership as chair of the department. I am a member of an academic department of medicine within a very large health system. And as you know, because we all did this, we prioritized COVID-related trials with everything else stopping for many, many months. So as I mentioned, we had an unprecedented amount of information to sift through, which had to be disseminated. Everybody was really banging at the doors. What do we do? How do we manage patients? What is the best approach? And a lot of the information on the internet was anecdotal, unsubstantiated. At the time, certainly at the beginning, before guidelines, were able to be developed. And again, very important, the emotional response to the day-to-day management of patients in the absence of evidence-based literature. So again, these are the elements of clinical leadership, which I mentioned. This is just a cartoon form. Communication key, respect for everybody, no matter what their roles were. Understanding that people did have personal fear of a new virus. And obviously, we wanted to maintain practice that was still high standard and ethical. So there's an interplay here among these 4 pillars. It's important that it's not just an individual, but a team leadership whereby everybody trusts members of the teams, and we have the tools, hopefully, to develop and tackle crisis. We at Forest Hills met as senior leadership 3 times a day for 2 months. That was in addition to system leadership meetings. We went through tremendous, discussions. What do we need? What do we have to do? And importantly, if we had to change direction quickly, which we did do, how does that information get communicated? So we are beyond the first surge, but we are really not back to, quote, normal. We have eliminated surge units. Anybody now who comes in with COVID, and again, it's mostly an unvaccinated population coming in requiring hospitalization. We do cohort patients. We have tremendous community outreach to convince people that they should be vaccinated. And we certainly are out there as well, taking care of the community. And, in terms of what worked, what didn't work, and how do we modify this for the next time. So to leave you on a positive note, this is actually the Northwell Health Nurse Choir that competed in America's Got Talent. So again, really not only teamwork, but ending my brief presentation on a very positive note. And I thank you. So let me stop the screen share. And there we are.
And thank you very, very much, Miriam. That's an excellent presentation, and it's a very good segue into what I'd like to talk about. I think that the subject of leadership in COVID-19 is something that every single person has to take huge responsibility for. And I want to thank the ACP for the leadership role that they've played in putting together tonight's program. I think that having programs like this, relatively informal, and I'm not really going to do a full slide sharing with everybody, but I just wanted to do a couple of slides. As Miriam spoke, I said there are a couple of things that I'd like to accent and focus on from her excellent talk. And Miriam is very young, but we're old friends, as she
Oh,
mentioned.
thank you, Aaron. I appreciate
And
that.
two ID guys getting together after all these years talking about COVID is not something any of us would have ever imagined. We thought we went through everything. Both of us were around at the very beginning of HIV infection. Both of us have been through a number of very serious potential worldwide threats like Ebola and smallpox scares, H1N1s, and all sorts of other interesting potential infectious diseases. But certainly, I don't think there's an infectious disease person around that would say that COVID is not up there with the top, if not always rated as the top infectious diseases that we've had to deal with in our career. And this has been so uh, ever present in everything that we do. I don't recall a single meeting at the hospital in the last 2 years that hasn't had the word COVID in it, no matter what the meeting was about. And that's why this is such an important idea. And I'm not going to update you on infectious diseases, but I would like to give some credit to a lot of people. And that's really part of leadership. And I think one of the major things I've learned in leadership is that you can't be a good leader without having a great team. And I know at our hospital, I know, Miriam feels the same way at her hospital. And I know the ACP with Amanda and all of the people at the ACP, they have a great team as well. And each of us has our jobs to do. And none of us would be successful if we did our job without the help of everybody around us. And I love to show this slide. It's stolen from some internet site, so I can't really give full credit to anything other than this R.J. Romero. But this is exactly what we were dealing with, having shiploads of information coming in, regulations coming in that were changing from day to day. They're offering different from regulatory body to regulatory body. And that made things quite difficult. But I would be remiss if I didn't recognize all of the infectious disease attendings at our hospital. And they did yeoman's work, and that's not to exclude anybody else. The physicians across the hospital in every single area did unbelievable work. As Miriam mentioned, many people went out of their normal roles. We had lots of our staff in our ambulatory sites, which were often closed, coming into the hospital, functioning as sometimes phlebotomists. We had anesthesiologists who weren't working in our closed ORs, functioning as respiratory therapists. We had people who hadn't done some of the jobs they were being asked to do for years, and some of them never at all, were rapidly being trained. And we had critical care specialists having teams underneath them made up of a hodgepodge of medicine subspecialists, students, residents that were outside their normal area of comfort and expertise, and yet they did unbelievable job. And what made it so especially difficult was this was a totally unknown entity. And when you think back on it, how much information we learned about this virus in such an unbelievably short period of time, that to me is the real miracle, if you wish, of our dealing with COVID. When you think about the average time to make a vaccine being 11 years, and Ebola, which was rushed through, took 5 years, and yet we had a working, now we know, highly efficacious and very safe vaccine within 6 months of the first case in the United States. And we were mass vaccinating people within 10 months of the first cases in the United States. And at this point, we vaccinated billions and billions of people in the world when we're still within, in some places, a little bit more than a year and a half from the onset of cases in those countries. And this was I think the leadership across the board, the major regulatory agencies like the FDA and the CDC, the NIH, IDSA, ACP, they've all taken a lot of heat. And I think that we have to acknowledge and recognize that they did superb jobs. Well, not perfect jobs. There's nobody on this chat that can say that they did a perfect job. But I can't imagine anybody truly thinking that everybody who was working on this didn't try the best that they could. And the major message we tried to get out to our staff was to thank them constantly. One of the things that we did, I never realized I had this in me. I used to be a waiter when I was in college. That's how I helped pay for college and medical school, was by waiting tables. Well, I became a food supplier again. And one of the roles of leadership was to make sure that our staff was fed. It was difficult for staff to have time off to go out. Cafeteria wasn't open around the clock. We had so many people that wanted to help out in the hospital. I think one of the nicest and kindest things that I can remember is how local restaurants, local food establishments, local grocery chains sent over tons and tons of food to the hospital. And local businessmen sent over money and said, listen, buy lunch for the nurses, buy lunch for the staff. And we really were so appreciative. Not that anybody really needed the $5 meal, but people didn't literally have a moment's break to sometimes even grab a sandwich, and to find them right where you needed them was, I think, an example of leadership on the community's part. And I think that while this was an extremely difficult pandemic, this pandemic really allowed a lot of people to shine. There were so many different challenges that we had. We developed testing. When I say we, I don't mean myself. I mean the scientific community developed testing for an illness that we didn't know about. And we had tests within 2-3 month period of time, albeit it was very difficult at the beginning to get such tests. But it was something that absolutely was critical in our ability to diagnose. I remember back in February when we had our first patients, we didn't have a way to identify that they had COVID. We thought they had COVID, but we had no way of proving it. And as a result, people weren't put into isolation early enough before we realized how highly contagious this illness was. And I know many of our staff early on caught COVID from patients when we had no idea that the patients that they were seeing actually had a contagious illness, because they didn't all have the classical presentation. We didn't understand the GI presentation at that point in time. We didn't understand some of the other presentations. And unless you had a clear rip-roaring pneumonia, people weren't necessarily being put into isolation. So there were many, many diagnostic challenges. And the staff really rose to the occasion from every field. I can't believe how many environmental service workers, the housekeepers, people who went into clean rooms, they were willing to put themselves at risk. And that's because the message that we constantly got across to everybody and tried to get across to everybody was, we have your back. We tried to make things as safe as possible as soon as we realized there was a need to do something, as soon as there was a need to provide all sorts of personal protective equipment. As Miriam had mentioned, the big advantage of working in a system such as Miriam works in, or as I do in the Mount Sinai system, is that these are large, highly professional, well-trained procurement teams. And we, thank God, never had to, we were challenged with getting adequate personal protective equipment, but thank God we never had to skimp. We never had to tell a staff member, no, you go into that room without the proper protective equipment. We learned how to reuse things that we never thought about reusing. And my career in the thank God, very wonderful United States of America, who ever thought about reusing a mask? The farthest thing from anybody's mind, that you took an N95 and you went into a patient's room with tuberculosis, you took it off and you threw it away. Who would ever have thought that we'd be reusing equipment? And again, part of the leadership was to make sure that all of the staff felt protected, whether it was eye shields, goggles, whether it was making sure that people had impervious gowns when they needed them, that people had appropriate gloves, people had certainly all the masks that they needed. So that was, I think, an example of tremendous leadership on the part of the system to make sure that we all had what we need. We disseminated this information. It's critically important for people to realize that if you don't instruct people, if you don't tell them everything that they need to know, and as Miriam said, even if the answer is sometimes, I don't know, but this is my best guess. So we were working by the seat of our pants very frequently in this pandemic. We opened up early on an outpatient infusion center to give monoclonal antibodies as soon as they became available. Before that, we were giving plasma therapy. We motivated our community to donate tremendous numbers of plasma. In some of the areas around our hospital, we were also at the epicenter, and there were tremendous numbers of patients who had, thank God, recovered and wanted to do something. And we mobilized plasma donation. Mount Sinai had developed the original antibody test that the New York Blood Center used. And therefore, we were able to know exactly which employees, which patients in our community had adequate antibody levels to then be able to have plasma taken from them and to be used. We were able to do things with unbelievable alacrity compared to the way normally things would go because of the communication and the camaraderie between different institutions, between departments of health and the hospital. And that really made, I think, a tremendous difference in us being able to combat this epidemic. And public education, I think, is very important, keeping the community abreast. We did a tremendous number of streaming events, live streaming events to the community, keeping them informed what was going on, and having question and answer sessions on various types of Facebook stream or other types of social media to make sure that the community was kept up to date in what was going on. And our PR community, our public relations community, they made sure that we were getting the message out to the local community so that when people had concerns, they did have a way that they could have those concerns addressed, either in a formal or an informal manner, as the hospital took many questions from people in the community. And finally, when vaccinations became available, so our hospital got a grant, and we have our very nicely named Vaxmobile, which is an old trailer that was refitted and refurbished with a grant from the town of Hempstead to allow us to bring vaccinations to the people. We had one of our MPs, this phenomenal lady by the name of Amber Vitale, who went to homebound people's houses on her own time sometimes to go and vaccinate them in their home for people that weren't able to come out to either the Vaxmobile or to come to our vaccine pod. The hospital set up a vaccine pod in a matter of a weekend, converted an old, relatively unused space off our campus and made it into a vaccine center. And the hospital provided over 50,000 vaccinations during this period of time. Again, you're going from 0 to 50,000 in an extremely short period of time. And kudos to all of the people that made that happen. And I think that's part of leadership as well. And that you had many of our retired nurses, some of them recently retired, who came back to staff those vaccine pods because we were so short-staffed. We couldn't afford to take people out of their regular jobs and suddenly open up these tremendous centers for additional services. We had a drive-through. We still have a drive-through PCR testing program. We went to the community and started some PCR testing programs in the community with a grant from the Nassau County County Executive. We worked very closely with the Department of Health in Nassau County to go and make sure that we would be able to help them as they helped us to make sure that all of the needs of the community were taken care of. And that's something that hospitals maybe didn't do as much in the past, but I think we need to be at the forefront of taking care of the outpatient scene as much as we do the inpatient scene. And the inpatient scene was crazy, as Miriam had mentioned. We're officially a 450 bed hospital, but most hospitals never staff really what their license says. And we run in a census of 350 or so on a given day. At the height of COVID, on our busiest day, we had over 400 patients with COVID in the hospital, a total of over 500 patients in the entire hospital. We're not even licensed for that much. As Mary mentioned, we were required by law to increase our capacity by 50%, which we did. But even with that increased 50% capacity, we were essentially taking care of 400 ICU patients in places such as tents, in some of our parking areas, in areas that were previously conference rooms. We set up an infusion center in one of our old conference rooms and made it into a 25-bed infusion center. People improvised and people innovated. And I never heard, even one time during the entire pandemic, I never heard, and I can say this honestly, I never heard one person in the hospital say, I'm not doing that. We sometimes heard that we can't do certain things after we tried. Not every innovative project that we did was successful, but many, many of them were. And I think that we sometimes take for granted how hard we expect everybody to work in the middle of a pandemic, and everybody came through, and I couldn't be more proud of them. And the last thing I just wanted to say is that it's extremely important to remember that we primarily have a job to educate the community. And one of the things that upsets me probably more than anything else is when we have a patient in our ICU who comes in and unfortunately dies and they're unvaccinated, because this is a preventable illness. If somebody comes in and gets a stroke and we took care of their blood pressure, we got them to stop smoking, we took care of all of their risk factors, and then they get a stroke, there's nothing I could have done about it. But when somebody needs just a simple shot, a one-shot J&J, a two-shot mRNA vaccine, and they don't get it because of misinformation, they don't get it because we haven't maybe adequately explained to them their concerns. We have a lot of misinformation to combat, but it's sad. To me, it's very sad when we can't get people who are at high risk to vaccinate. And I think one of the primary jobs of everybody on this chat, and every physician and every public health worker, is to make sure that we get out the right message, that we get out that you can't take all of these prophylactic medications that people are taking out there that are of zero proven benefit. And what's worse is, even if they're not a proven benefit, they prevent people from sometimes getting vaccinated. They prevent people from taking proven therapies. They delay in coming in to get a monoclonal infusion, which can be life-saving. They delay in coming in to get oxygen therapy because, oh no, by taking this product, I'll be okay. It just takes a couple more days. And that's what's sad. And that's what I think we all can do better. And that's to combat misinformation that's out there on social media. And if each of us talks to our patients, each of us talks to our community, then I think we really demonstrate leadership as physicians. So it's a true honor for me to be on the program tonight with Miriam. I thank Amanda as well. Best introduction ever. I always like to be called a nice guy. So I thank you very much for having me here. It's an honor to share this stage with Miriam and the ACP. And I think at this point, we're really open to questions from the audience. And I hope people have good questions, because we'd love to hear what you have to say. So we can either turn it over back to Amanda as a moderator, or people can speak up. It's a workable enough number that I think people, if they just want to speak up, if we get crisscross from people, so somebody will be polite and let the other person go first.
I agree. Please feel free to unmute yourselves. You can use the chat if you feel more comfortable with that. And if you want to raise your hand, the raise hand feature is at the bottom under reactions. But we definitely welcome questions, comments, discussion. I don't have any questions in the chat right yet, Dr. Glatt or Dr. Smith.
Miriam and I aren't anesthesiologists. We didn't put you to sleep.
No, we hope not.
So ask us questions. It doesn't have to relate specifically to what we talked about. It could be your take or your concerns. How we could do a better job is always what I like to hear. It's nice to get accolades. It's actually much more helpful to get, valid criticism or valid suggestions so we can do better the next time.
Dr. Davsvaj, go ahead and unmute, and then we do have a question in the chat next.
Yeah. I think, all of 2020 was really difficult. But then, things were looking better over the summer, and then Delta. And now, there's surges, not so much in New York, but I'm just wondering if, like out on Long Island, you're seeing like little sort of groups of people that are are really virulently anti-vax and are getting sick and causing like mini surges in these communities. Or is that pretty much over? Like nobody has to expand capacity anymore for like a mini surge of the fall and the winter?
So I can tell you, because I follow these numbers on a daily basis. In our health system, we've been hovering between 9 and 12% of COVID patients, total capacity in our entire health system, which is much improved from the summer.
Right.
We're hoping that vaccination, the current vaccines are effective, have been effective against any of the variants so far. And we're hoping that, I don't think this virus is going away. I think we will always be seeing some of it. But it's been more manageable Certainly with this, current, with the summer's increase, we haven't had to reestablish surge units. At least we haven't, even as the numbers have gone up and then come down again. But I think we're all a little more able to handle patients. There is more information, and the community is much more readily vaccinated than it was, say, 2 months ago. All of that is very helpful.
Yeah. I mean, isn't the goal to make this endemic rather than pandemic with annual boosters of some sort?
That would be what I would anticipate. And what about you, Aaron?
So I agree. I think that our experience has been the same as yours. Our raw numbers, we hit over 400 in the first wave. We went up to about 140, 150 in the second wave. And thank God this wave we didn't break 25. We came close, but we didn't break 25.
Right.
So I think as more and more people are vaccinated, even if there are vaccine breakthroughs, which there will be, even with only 2 shots, you're going to get much, much less severe disease. We haven't had, with one exception, any patients in our ICU that have been vaccinated fully. And most at-risk patients probably should be getting a booster shot at this point in time because they're beyond 6 months from when they originally got their first series of either the 2 shots or the 1-shot J&J. And those people clearly, based upon data from Israel, especially, but also published from the Yale New Haven system in the Lancet, from England and other places, clearly demonstrate that while the vaccines are unbelievably still good in preventing serious illness, you will have some breakthroughs of severity in older patients, especially above the age of 50, 60, then 70, 80, even more. And you will have people with underlying comorbidities. That's separate from the people that never really responded in the first place. The people, let's say, that had a solid organ transplant, have a horrible leukemia, heaven forbid, and they never really responded in the first place. But people that did respond, their immunity will wane somewhat. And many have suggested, and it may be true, that this should have been a 3-shot series from the start rather than a 2-shot series. And whether that would be all that we'll need, we don't know. Hepatitis B is a 3-shot series. That's not strange, 0, 1, and 6 months. Maybe this type of vaccination will require a 0, 1, and 6 month type of vaccine to give you lifelong immunity. Whether we will or will not need boosters beyond the 3rd shot is really unknown. But people do need to realize that the vast majority of patients dying in the United States right now, the vast majority of patients intubated in ICUs, severely ill, are unvaccinated. And that's a message we have to get out. Colin Powell of blessed memory, who just died, the anti-vax community is having a love fest with his death, unfortunately. Look, vaccines don't work. So he had underlying medical conditions. He was of an age, and he was actually scheduled to get his booster last week when he got sick. And so sad, because he was an absolutely vibrant 84-year-old, but he had significant risk factors. And to use that as an example of the vaccines not working is a shame, because there are so many people like Colin Powell who didn't get COVID. But we need to get the message out there that these vaccines are unbelievably life-saving. They're unbelievably safe. They don't cause infertility. They don't cause all sorts of crazy problems that are out there on the internet. I got an email. I wouldn't believe this, half an hour before this program started, asking me how dangerous are the nanoparticles that we're injecting into people with this vaccine. This is a half an hour before this program started. This is the chips in the vaccine that we're going to control people. We're going to have an on-off switch, and everybody's going to die, 2 years after the vaccine is given. This type of ridiculous nonsense has to be combated, and everybody on this chat has the ability to do so in their sphere of influence. If you have a really large bully pulpit like Anthony Fauci, so you can do it on that level. But you can do it over coffee with your friends when somebody says a silly comment. Instead of ignoring it, say, no, that's absolutely not true. Where did you get that information? Oh, I read it on Facebook. It can't be anything more true than that. And you have to explain to them why it's nonsense. And we have to nip this in the bud. We really are facing an epidemic still, and we can combat it if all of us combat it all the time.
I have one other question about spacing of vaccines. In Italy at one point, I think like 2 shots of whatever they were using there were scheduled 12 weeks apart. And there's some evidence that delaying the second shot will increase the immune efficacy of the vaccines.
So some people suggest that that may be why the Moderna seems to be slightly better in terms of the levels of the antibody present. Maybe that 1 week makes a difference. And everybody has to realize that the number 3 weeks for Pfizer, the number 4 weeks for Moderna were picked out of a hat. It wasn't based upon any scientific evidence. It was a reasonable approach, and both of them were right. Whether one is a slightly more optimal dosing regimen is unknown. In England, they really advocated giving only one shot to as many people as possible and then giving the second shot. And they certainly had less immunity. I think it's clear that a single dose of the mRNA vaccine provides some benefit, but certainly nowhere near as good as having 2 doses of the mRNA vaccine. So I wouldn't advocate going to a 12-week like they did in England regimen, but whether it's a 3-week, 4-week, or maybe even a 4 or 5, 6-week regimen, we don't know. But I think giving that second dose at some point in time will probably be necessary for many people, if not all people. Certainly, the data from Israel support that people under the age of 40 don't get seriously ill, even if they do get a second episode of COVID. 40 to 50 has a slight increase in the number of serious illnesses, but still extremely minimal. When you hit 50, and you go in the decade from 50 to 60, you start having, again, a slightly higher, but still most of the people aren't going to be seriously ill, but you will have a death or two in that group. Now, it's unclear whether those people never really mounted an immune response. But certainly once you start getting into more senior years, it is clear that there will be some breakthroughs, and that, in my opinion, I think it's very reasonable to assume that most people above 50 either have underlying morbidity or underlying comorbid conditions, or they have, just from age alone, reasonable to give them a booster after a 6-month period of time. For a population below that, I think we need a little bit more evidence. Undoubtedly, the immunity will be increased. The question is there any significant toxicity? And for most people, there certainly is not. So we recommend that, based upon the CDC guidelines, that people who are in high-risk populations like doctors or other healthcare workers, or people that are in a high exposure situation, maybe like a teacher in a preschool, or teachers in children that are under the age of 12 that aren't vaccinated at all at this point in time. So maybe it's reasonable to give them a booster as well after a 6-month period of time. Miriam, you have different thoughts?
We don't know. And it's interesting that, nobody is using antibody level to determine whether or not somebody needs a booster, because it's not clear. Number one, is there a level that's protective? And if you then drop below that level, are you no longer protected? Or more likely, there are other components of the immune response that come into play that provide either protection or not. So at the moment, the recommendation is, as Aaron mentioned, the high risk groups to get the booster with Pfizer, Moderna, the Moderna and J&J. I think it's going to be a mix and match. Within the next 2 weeks, it'll be put out officially, by the FDA. I think it'll be acceptable. There are people doing it anyway. You can go to your local pharmacy and get the mRNA vaccine with not much ado. So remains to be seen.
Thank you. Regarding we do have a bunch of questions coming in the chat, so I just wanted to pop in. You guys have gotten the conversation going, and please feel free, everyone, if you want to unmute, please, you're welcome to unmute and ask, but I will read the ones in the chat. I believe the first one was answered, where do you anticipate a similar COVID surge in the future? And it sounded like you were saying your numbers were getting lower each surge with the vaccination growing. So if you want to elaborate on that, you can. The other one was, and it sounded like we don't have any word yet, but somebody was wondering, is there any word on the Moderna third vaccine shot? So I'll stop with those 2 questions, because then we have 2 more.
It remains to be seen, and I think the recommendation is almost forthcoming with respect to Moderna, and again, the mix and match. I think we have a very short period of time before we expect that as a formal, really a formal recommendation.
Thank you.
And I would agree with that also. And I think the mix and match is very important. I think that, sometimes people can't get the vaccine that they, quote, got originally for whatever the reason. And I do believe that the ultimate opinion will be that get that second or third dose, depending on what your original series was, with any one of them. There's at least theory to suggest that maybe giving a different vaccine might be beneficial. There's theory to suggest that it is not beneficial, better stick with the original one. So until we have more hard evidence, I think the mix and match approach is reasonable, and we'll see eventually whether that's actually recommended or it's just if you have no choice. I think for the people that got the J&J, they absolutely should get a second vaccine dose, whether it's J&J or one of the mRNA vaccines. I think a lot of people are going to probably suggest that it be an mRNA vaccine, but I don't have a strong preference. And I think the people who got the single dose J&J should definitely get a second dose. They don't have to wait 6 months. The recommendation probably would be wait 2 months and then get your second dose. In regards to the dosing itself, the Moderna dose that will be approved for the booster will be a 50 microgram dose, which is half the dose of the original one. No real evidence that the original dose would not have worked. It probably will work fine. The thought process is that maybe you'll get some lesser amount of side effects. The Pfizer third dose is the exact same 30 microgram dose that the original two were, and whether a lower dose would be of benefit or not. The Israeli experience, again, has been that the Pfizer dose did not cause any additional side effects compared to the second dose. So you don't get, well, the first dose was mild, the second dose a little bit more severe, third dose is going to be much more severe. That's simply incorrect. The third dose had exactly the same amount of side effects, local side effects, nuisance type of side effects, as well as more serious type of side effects in the same amount as the second dose of the Pfizer vaccine. So that's reassuring as well. And then I think the other comment was, will we expect to see more of this in the future? As Miriam said, I don't think anybody in the infectious disease world thinks that we're going to eradicate COVID in the near future, whether at some point in the more distant future we will. And certainly if molnupiravir and other antivirals are much more effective in preventing serious spread of illness in addition to treating those people, so then we do maybe have a potential to really get this under much better control. But until all parts of the world are vaccinated, the potential for getting something besides Delta. Delta is highly, highly contagious, much more contagious than the original strains. What happens if there's a super Delta that comes along? What happens if there's a more resistant Delta? The vaccines work well against Delta. What happens if a mutation occurs that the vaccines no longer work as well against? So I think we have to be vigilant and make sure that people across the world get vaccinated.
Thank you, Dr. Glatt. Speaking of kind of mix and match, what about when we're talking about the flu vaccine and COVID? Should it be spaced out for better immunity when we're talking about mixing or taking it with other vaccines?
There's no downside to taking them together. I don't know that there would be any benefit to spacing them, but there's certainly no downside to. I actually did one arm and the other arm with an hour apart when I got my booster. One arm flu and one arm third.
That's what the says is
my arms were sore. But there are no data to say that one will reduce the antibody response of the other if given at the same time. That's pretty much where that is.
That's the official CDC on their website says you can take both at the same time. They recommend taking them in different arms. I tell people, if it makes you nervous, get the COVID vaccine first. And as soon as you're ready, get the flu vaccine. Because some people have told me I'm scared about getting both at the same time, or I'm scared if I get a side effect and it's my first COVID shot, will I not be able to take the second COVID shot? While I don't think that there are, as Miriam said, scientific reasons that you can't take them both together, it's not going to impair the immune response. If a person has either an emotional or a psychological reason that they don't want to take them both together, take the COVID shot first and take the flu shot whenever, a day later, a week later. There's no reason to wait, but if it makes you more comfortable, if it will get you vaccinated, then I have no problem with somebody waiting.
I like that. And I like, it seems like that's popular, and I like the one comment, it's why we have two arms.
Yes. Thank you.
Great. I love it. So we have two other questions, and both are related to community a little bit. One says many people in our community are refusing vaccines as they believe they have polyethylene glycol or PEG allergy. Could you comment on that topic?
You want to take that one, Miriam, or you want me to?
Feel free, Aaron.
Okay. So people who never heard of the word PEG in their life suddenly have PEG allergies. When medical exemptions were being submitted, people said, well, I once put on gloves that had PEG in them, therefore I can't take the vaccine. That's a true statement. So the official policy is that if you had an injectable medication that had PEG in it and you had an anaphylactic reaction to it, go see an immunologist. It doesn't even mean it's an automatic contraindication to getting the vaccine. We had one respiratory therapist who was extremely desirous of getting the vaccine, but she did have a PEG allergy. And we vaccinated her under supervision, and she did fine. So I'm not being callous about anaphylactic reactions. I'm extremely aware of them. But I'm also not going to be callous about how severe COVID-19 can be. And it's not a disease anybody wants to get. The long COVID concerns in young children terrify me because everybody's very cavalier about young children. And what is that going to mean to their ability to function well in school? Are they going to go from an A student to being a C student because of COVID fog, because of all things that we don't understand? Everybody's concerned about what's going to be 20 years from now with these mRNA vaccines. I'm going to turn into the Hulk. So that's not realistic. But it is realistic when half the population at 3 months and maybe a third of the population who had COVID at 6 months still have significant symptoms. Well, what does that mean for a 6-year-old kid? What does that mean for a 15-year-old kid? We don't know. And that's what I'm concerned about. So I think that we need to stress to people that there are many unknowns here, but they certainly overwhelmingly favor vaccination. And I would tell people, if you're concerned about an allergy that you've had in the past, see an immunologist, see an allergy immunologist, and they can do skin testing and they can do other appropriate testing. You can get vaccinated under an emergency room type of a setting. You can get vaccinated in a situation where, heaven forbid, if you get anaphylaxis, it can be easily and rapidly treated. And there haven't been, to my knowledge, any deaths from anaphylaxis from these vaccines. The cases that have occurred have all survived and done well as far as I know. And certainly you're talking about 5 billion doses of vaccine having been given. So the concern about PEG is way, way, way overstated in my humble opinion.
No, thank you, Dr. Glad. Amanda, may I ask real quick, please?
Sure.
So Dr. Glad, so that's a question I posed.
Andy, you're on mute.
Oh,
Thank you. Yes, sure, Dr. Patel. I know that was your question, and I just have 2 questions after.
Okay, then I'll be quick. I promise. Thank you. So, Dr. Glass, so I raised a question about polyethylene glycol because we had a few people who have refused that because of that, and we sent them to allergists, and they said they cannot rule out just based on the skin test. Is there something you and I can talk offline, or you can just or Amanda can get us connected to see, is there what's appropriate testing I can do, because we have 3 or 4 people who are saying no because of PEG allergies, and our allergies are not able to exclude.
So the PEG allergies, if they had a PEG allergy, there was a PEG allergy to an injectable device, they should be seen by an appropriate immunologist. And I would defer, I'm not an immunologist.
Sure.
I would defer to the immunologist's decision. Almost all of the immunologists I've spoken with have said that they are able to vaccinate most of these patients without a concern.
Oh, that's helpful. Thank you.
But that's something an immunologist should really weigh in on. Patients who've had PEG allergies, quote, through either oral compounds or through contact, I don't think that's at all a contraindication. I don't think that's an indication to go to an immunologist. But if it will make them feel better, we have to understand that patients have concerns that sometimes aren't valid scientifically, but they're valid as people. And those concerns need to be addressed. We sometimes are paternalistic. We sometimes are dismissive, and we need to understand that if we want the patient to get vaccinated, we have to make them want to get vaccinated. It's not enough for us to quote chapter and verse saying that they should get vaccinated.
That's a good point. Thank you.
Thank you, Dr. Patel and Dr. Glatt. We have 2 minutes remaining, and I have 2 questions. So I'm going to throw out both questions so you know what they are.
Lightning round.
It is the lightning round. You ready? So the first one is I truly enjoyed hearing and learning about the vaccine mobiles. Are there plans to implement them in the future to additional communities? And the second is, how are you affected by the vaccine mandate? We have lost many staff.
So I'll take the Vaxmobile one, and Miriam, you can address the mandate one. So our Vaxmobile is every day goes to a different community. If people ask us to go to the community, we try to work it out. We work often with churches and temples and school systems and larger organizations, so we can get a base, so we don't send the Vaxmobile out there without a lot of notice, so we can try to get as many people vaccinated as possible. If anybody wishes to arrange something for their community with our Vaxmobile, please go to our hospital website, Mount Sinai South Nassau. Google Vaxmobile, you'll probably come up with the same information, and speak to the people at that phone number, and we can try to arrange a date for our Vaxmobile to come to your community. It's a grant from the town of Hempstead, so we can go pretty much any place in Nassau County. So we try to stay within the town of Hempstead, but that pretty much covers our catchment area around our hospital. Miriam, it's all yours.
So, our health system is the largest single employer in New York State. And we were, preparing for what would happen when people who didn't want to be vaccinated were terminated, which is exactly what did happen. So our health system basically employs many thousands of healthcare workers, providers, et cetera. 1,400 people were terminated as a result of the mandate. We did not have, honestly, as much, it didn't have as much of an impact as we had anticipated, fortunately for us. So again, from a Northwell standpoint, it was absorbable. And again, we've been functioning okay, despite that number of people who were terminated.
Thank you. Those were all the questions. You did fantastic in the lightning round and the whole thing. So I just want to thank everybody for coming tonight. Dr. Glatt and Dr. Smith, you shared so much information between leadership and COVID. I think it was quite a night. So thank you so much to everybody who came and asked questions as well. I did pop in the chat if you scroll up, our upcoming events, if you'd like to join us for another event, as well as a link to our recordings page that you can bookmark as well. This will be available on the recordings page. So you guys can pass it on to anyone who might be interested, or use it for future reference for yourselves. Dr. Glatt and Dr. Smith, did you want to have any closing comments? I'll leave you to it.
Thank you, Erin, for being a great co-chair. Thank you, Amanda, for inviting me and allowing us to use this forum to really describe what we went through and how we can share it, how we could share that experience. So thank you to everybody. I know it's getting late, but much appreciated for your attention.
I'll just say ditto. Miriam said it all. It's an honor and a pleasure to be here, and thank you all for listening.